So objectives of the discussion today, we'll go over some real world examples and some case studies in stroke and PFO closure. We'll go over a little bit of the workup and evaluation for how we address cryptogenic stroke in the clinic and in the hospital. And we'll discuss a little bit about the interventional and medical therapies for PFOs in the setting of cryptogenic stroke. So as a summary and highlight, most of you know cryptogenic stroke, but the data is interesting in that it accounts for 10 to 40% of all ischemic strokes. That percentage is pretty broad, and it's broad because in the advent of more aggressive and thorough monitoring and evaluations of patients, the true cryptogenic stroke rate has gone down significantly. Whereas 20 years ago, it was about 40%, maybe a little less than half of patients we would say we don't have an underlying cause. In this era, we really advocate that if you look hard enough for stroke, usually the number of cases that you see where there really is no known explanation is quite low. And I would say that's really more in the 10% range. It underscores what we're going to talk about later in this discussion, that a really thorough, dedicated evaluation of cryptogenic stroke by looking at all the risk factors and looking at all of the possibilities for stroke will help make these numbers lower. Ideally, at the end of the day, most of our cryptogenic stroke patients, we want to be able to say, we found the cause, here's what it is, and here's how we're going to address it. Cryptogenic stroke accounts for anywhere from 120 to 180,000 patients per year. We really consider it cryptogenic once an adequate workup has been performed and we don't find an alternative explanation. As Jeff Saver wrote in a very great article about cryptogenic stroke in the New England Journal in 2016, he distinguishes between highly cryptogenic, meaning there's no probable and no possible cause discovered, versus possibly determined origin, which means patients where we come up with some red flags or some possible smoking guns and say, I think it could be one of these causes, and that really will help moving forward with how we treat and manage these patients clinically. Cryptogenic stroke in the New England Journal in 2016 sort of clarified. He said there's highly cryptogenic, which means there's no probable and no possible cause, and then there's sort of moderately or mildly cryptogenic where there's a possible origin. And those are really some of the cases that we want to discuss. So in terms of his history, he has no past medical history. He denied any illicit drug use or tobacco use. He doesn't have any allergies. He takes no medications. And so these are the important questions that we asked him, and we ask any patient who comes in who has stroke for an unusual reason or don't have conventional risk factors. We ask about drug use. Do they use methamphetamines, stimulants, or cocaine? Those are sort of the big triggers for stroke in the younger population under the age of 60. We've seen strokes with supplement use or stimulant use. So I always ask fitness buffs and athletes, are you using anything else? We've seen steroids do this. We've seen testosterone do this. We've seen some of these illicit stimulants that people use for training to cause stroke. We always ask about recent prolonged travel or history. It's really interesting in the COVID era, we're not seeing long trips anymore, but what we are seeing is a lot of people who say, yes, I'm basically just sitting at my house doing nothing for long periods of time. And so we do see some sedentary history in that regard. Recent illness or infection, particularly in the COVID area are interesting. I think the jury is still out on how, what the causative relationship is between COVID and stroke. We are clearly seeing on postmortem studies evidence of vascular inflammation of brain arteries in patients who've had COVID infection. But I think we need to be a little careful about interpreting stroke in the setting of COVID positive patients, simply because we're going to have so many patients who are COVID positive that it's not necessarily cause and effect. So an example is at our center, when we're seeing 78-year-old people with diabetes, hypertension, and hyperlipidemia come with a stroke who happen to be COVID positive but don't have symptoms, I'm not sure it's correct to say, oh, this must be because of COVID. So we've, I think, got to be thoughtful about who we attribute COVID-related strokes to. So do they have a family history of that? Certainly suggests, are there underlying issues that would potentially lead to stroke, either whether it be genetic risk factors or hypercoagulable risk factors. And then we always look for recent histories of head or neck trauma, the types of things which could cause arterial insufficiency or problems. So then I had stroke. So score was 3. He had the arm and leg weakness, as I mentioned. He had some patchy sensory changes in his leg compared to the right. He was very emotional and pretty anxious, as you can imagine. This guy's a pretty young guy and is having a stroke, and he more or less knew it. And this is his original CT scan. So his original CT looks okay. There's really nothing significant here. On his CT angiogram, you can see no real clear pathology, no large vessel cutoff. Sorry, I know it's a little hard to see because the image is small, but his vessels look okay, take my word for it. And then this was his MRI. So his history is really interesting. I was all set on geared up to give him TPA. And I asked him the question that I always ask TPA patients right before I give it, which is essentially, do you have any history of bleeding problems or any issues with bleeding? And he said, well, I don't, but my daughter does. And I said, what do you mean your daughter does? He says, well, my daughter has von Willebrand's disease. And I said, oh, that's interesting. And I said, do you have bleeding problems? And he says, yeah, I actually bleed a lot, but I've never been diagnosed with anything. So suddenly I took a step back and said, I don't feel totally comfortable giving you TPA. Your stroke deficits are mild. Let's do an MRI and see what it shows. Here's his MRI result. So his MRI result shows an area of restricted diffusion, which you can see here. This is actually old. So this is not a new lesion. This is his new one right here. And you'll see it on this study. That's his new stroke. This is actually a prior stroke that he didn't even know he had. And when you look at it on T2 weighted images, you can see this subtle intensity here on T2 suggests that this is not acute. This is actually something that's probably been subacute or longer. So now you suddenly have an individual who's not only presenting with a new stroke, but he's also presenting with an older area of possible gliosis from a prior stroke that he may not have known he had. So his echo with bubble study, as could maybe be expected given the context of this talk and this discussion, he did have evidence of positive PFO. He had agitated saline contrast at rest and with Valsalva, which was consistent with the PFO. The rest of his heart structure was normal. He went on to have a transesophageal echo, which showed a PFO with an atrial septal aneurysm. His PFO is felt to be high risk for embolism. We didn't see any thrombus in the left atrial appendage. The aortic valve was normal. Everything else looked okay. So here are the AAN practice recommendations that were released earlier this year. So it basically determined that in patients being considered for PFO closure, TCD with agitated saline can be used as a screening tool. This does not obviate the need for TTE or TEE. And then I bring this up because there's often a lot of discussion about the best format for imaging patients with PFOs and what are the best screening tools. Here's sort of what we've relied on. There's a number of studies that have looked at this. There was a big meta-analysis looking at TCD. We use a lot of transcranial Doppler because in a lot of the literature, it's felt to be more sensitive than TTE, but it's less specific. But when you look at sort of selective trials and selective data, this is one, for instance, which was interesting, showing that TCD was superior to PFO detection even compared to TEE, possibly because one of the limitations, as I think the cardiologists listening in know, is getting adequate Valsalva efforts in a sedated patient who's getting a TE isn't ideal. And we can certainly get a better Valsalva during a transcranial Doppler. So in this particular study, it was interesting because the TE failed to show a right to left shunt in about 15% of the patients. And of these missed shunts, a quarter of them were grade 3 or higher, felt to be significant. This is another study that actually looked at transcranial Doppler versus transthoracic echo. And essentially, this is what it's showing, which is consistent really across a lot of trials, is that TCD is very sensitive, maybe not as specific. TTE is not as sensitive, but very specific. So I think a good protocol for trying to decide how you screen these patients, it's largely based on your center, because what we all know from doing transcranial Doppler as well as doing transthoracic and transesophageal echoes, they're very user dependent, they're very technician dependent in terms of how good a study you get. What we like to do at our center is it's really easy for us to get transthoracic echoes. If those are negative in our patients, we'll often do a TCD, and if the TCD is negative, we don't go any further. If the TCD shows that there is evidence of a PFO with shunting, then we'll usually go to TEE and look for more conclusive testing. So this is sort of, I think, the definitive statement is if you have a positive TCD or a positive TTE, I would do a transesophageal echo. It must be performed because you want to localize the shunt. You want to make sure it's not an atrial septal defect. You want to make sure it's not a pulmonary arteriovenous fistula. You want to make sure there isn't something else structural with the heart that could be causing this. And we always want to do TE as follow-up. This is an example of TCD. If you haven't seen transcranial Doppler, what you're seeing in these imaging studies are the different grades of quantifying the degree of shunting seen. Grade 1 are a few of these what are called microembolic signals, which are those brief, as you can see them here, shooting little spikes that come throughout the tracing. And then as you go to different grades, you can obviously by a grade 5, you have tons and tons of these microembolic signals getting across with a bubble study or another test. And this is sort of how we categorize and grade PFOs using transcranial Doppler. So back to this patient that we talked about. So venous Doppler of the lower extremities were negative. We always do a venous Doppler to make sure that he doesn't have an underlying thrombus in the deep venous system that could have been the source of a paradoxical embolization. He's currently undergoing prolonged telemetry monitoring, so he gets that for the better part of a month. We do a hypercoagulable workup, and at our center, hypercoagulable workup is protein C, protein S, antithrombin 3, homocysteine. You can see all the lists here, and we consider these all elements of a hypercoagulable evaluation. So the treatment plan for him is we plan on closing his PFO provided that his upcoming 1 month of telemetry monitoring is negative and that his hypercoagulable evaluation comes back negative. As I said, this is also recent. We don't have all those results back, but I'm going to presume all those will come back negative. Interestingly, his test and screen for von Willebrand's was negative. So he does not appear to have a bleeding disorder. So once we get those results, it's likely he will undergo PFO closure. This is just a brief overview and summary of the REDUCE study. And I think it's important because the REDUCE study is largely what dictated some of the changes in the American Academy of Neurology's guidelines on PFO closure. As some of you may or may not recall, several years ago, I think it was back in 2018, they said they couldn't recommend PFO closure based on the available literature and the studies that were done. And then once more data became available, they revamped their guidelines last year in 2020. So simply put, the Gore REDUCE study was a multinational study with 600 patients looking at a couple of the the PFO closure devices that are marketed by Gore, one of them being the Gore Helix and the other one being the Gore Cardioform. And the control arm for patients was antiplatelet therapy alone. They were not anticoagulated. They were just treated with antiplatelet therapy. And then the subjects were followed up for up to 5 years, but the preliminary follow-up was a 2-year follow-up, and then they had scanning. So it's important we consider what the inclusion and exclusion criteria were in these patients, because if we're going to close PFOs in the real world, we sort of want to mimic what's been done in studies and not try to deviate too much from what the study guidelines were. In this particular trial, patients were 18 to 59 years of age. They had to have had a stroke within 6 months. They had to have had an ischemic stroke, and the definition of that was either having had clinical symptoms for more than 24 hours, or they had an MRI that had evidence of infarction. Cryptogenic was defined as them not having any large vessel stenosis of greater than 50%. They couldn't have AFib. It had to be non-lacunar stroke. This is really important because one of the criticisms of some of the earlier PFO closure trials was that patients were getting enrolled in those studies who actually had lacunar events, and they probably did not have cardioembolic events. So we're very careful in this study to really choose patients with cortically based infarcts that really seem likely to have generated from a cardiac source. They can't have a hypercoagulable disorder, no other known cause of stroke, and the PFO had to be confirmed by transesophageal echocardiogram. This was the recurrent stroke risk, and this is what the endpoint showed, is there was 77% relative reduction in the risk of clinical stroke at 2 years with PFO closure compared to best medical therapy. The PFO closure was similar effect regardless of age, sex, baseline shunt size, and the number needed to treat to prevent 1 stroke at 2 years was 28. So you needed to treat 28 patients with closure to prevent 1 recurrent stroke at the 2-year point. This was a other endpoint that they used where they looked at the combined endpoint of brain infarction on closing MRI, which was done at 2 years, combined with clinical stroke events. And the reason this was performed was because there was concerns about prior clinical trials and not having enough power to detect a difference, since the recurrence rate for stroke in these studies was actually fairly low. So this was designed to obviate that. And again, what you're seeing here is a 49% relative risk reduction when you looked at the combined endpoint of new brain infarct or clinical stroke on patients who had closure. The technical success of closure were actually really high, meaning with both the devices that were used, there was a technical success rate of upwards of 98 to 99%, meaning the closure devices work. This is defined as freedom from a large shunt in patients after they have the device put in. So they seem to have technically be very good, and they tend to have a long-term benefit in terms of keeping the hole closed and limiting the amount of shunting. The adverse event profile in these patients, there was no significant difference in the overall serious adverse event rate. There was a low risk of device or procedure-related side effects. Deaths were uncommon. There were 2 deaths, one due to depression and one due to a patient with prior cardiovascular disease having an acute cardiovascular event. The biggest issue we have, obviously, with PFO closure, is seen in this slide, are the risks of AFib and aflutter. Atrial fibrillation and aflutter was obviously higher in the closure group. Most of these were non-serious, so about 2/3 of them were felt to be non-serious, would usually occur in the first 45 days, and oftentimes are usually in about 60% resolve within 2 weeks. So while we do see AFib not infrequently at the time of PFO closure, most of those are transient episodes that usually resolve spontaneously and independently. So with that being said, as sort of a summary and analysis of just one of the trials that was helpful at dictating our treatment and care, this is case number 2. So this is a 45-year-old patient who had a cerebellar and medullary stroke and was referred to our clinic here and referred to our hospital for an evaluation. This individual said the whole family developed COVID at the end of November. This individual had some symptoms of infection, and then about 4 weeks later had a minor cosmetic surgery procedure, said about a month after this presumed COVID infection. About 1 week after the surgery, this patient woke up with imbalance in coordination and some drooling. And this, after presenting to an outside hospital, they were found to have a left inferior cerebellar and left posterior medullary stroke. Interestingly, the left vertebral artery was occluded. They did not feel it was dissection, and they had a echocardiogram that showed a PFO, and they were sent to our center saying, well, we're concerned that maybe this vertebral artery got occluded because of the PFO. This is where the history comes in, and it's really critical because once this individual came to our facility, we did a little bit more detailed questioning. And oftentimes, as is usually the case, patients, I think, sometimes volunteer more information with every subsequent evaluation and question. And at this time, this individual said, oh, by the way, I did have a chiropractic adjustment after I got some headaches and neck pain after I got COVID. And we said, well, wait a second, what do you mean? You had to, well, I saw a chiropractor, they did a neck adjustment because I was having these terrible headaches that I thought were related to COVID. And that was a few weeks prior to when I ended up having that surgery. So we repeated the MRI scans, and we have the ability to do some thinner cuts through the brainstem on our diffusion images. And what you can see, and it's really subtle, is the arrows pointing at this little area of restricted diffusion right here in the lateral medulla and right here. And you can see it better on the coronal sections here. It's this little area here, and it's this little bright area right here. So this is this individual's stroke. And when you look at an MRA that we also did, here's the right vertebral artery coming up, and then the left vertebral artery, which comes around here, is gone. It's supposed to come off of the subclavian here. You see a little stub of it, and it would be going up like this. When you look at these axial sections here, here's the right vertebral. This is a special FAT-SAT sequence which looks for dissection. So this artery, this left vertebral is dissected, where you can see a little thrombus, it's acute thrombus in that artery right here and right here. And this individual had a dissection. So this is important in that just because someone has a PFO, we know the PFO rate is about 1 in 4 to 1 in 5. So there are a lot of people who you're going to diagnose with PFOs, even though they may have another cause for their stroke. And in this particular patient's case, this left vertebral artery was dissected. You always want to consider dissection, vasculitis, venous sinus thrombosis, focal arterial diseases which are either congenital, such as moyamoya, obviously coagulopathies as other causes for stroke. This is just an example and a diagrammatic of dissection. I think most people know about dissections, but they are common when the vertebral artery around the C1 and the C2 vertebrae gets stretched. This is a nice article and reference from AJNR that was published from the Journal of Neuroradiology several years ago, showing how golfers can get dissections because the C1 and C2 vertebrae twist on themselves and that vertebral artery gets pinched. This is case number 4. This is another interesting one. A 43-year-old gentleman who had no past history of TIA or stroke. He was in his usual state of health. He woke up and did his usual morning routine, went to the gym, had a workout. Around 1 o'clock, he developed acute onset of left arm weakness and sensory changes. He had some trouble speaking, had a left facial droop. He said that his left arm felt a sensation of paresthesias. He was able to walk, but he felt there was some incoordination in his leg. He was taken to the ER via 911, and by arrival, his deficits had largely resolved. Fortunately, he didn't have any left arm or left weakness or left leg weakness by the time he was in the emergency room, and he denied any headaches. Of note, this is pre-COVID era, so this is someone prior to 2020. He'd taken a trip to Cuba, And he said he'd been on a plane for a long time. And he did a lot of traveling extensively via flights. And then to complicate this in questioning, he actually said he'd had a mild viral illness a week prior, and he was doing a lot of coughing with that. So the reason these questions are relevant, we always ask these of our patients where we're concerned for PFOs, is extensive prolonged sitting on plane flights is a big trigger. Having had a viral illness, we ask people if they're coughing, because if they're coughing, they're valsalvating a lot, and that'll often cause paradoxical embolization from the right side of the heart to the left side of the heart. So we felt that these were pertinent risk factors for him. Here was his original imaging study with the CTA showing no significant arterial stenosis or occlusion. On his exam, he had an NIH stroke score of 2. He had a subtle left facial asymmetry and some sensory changes in his left arm. And here's his MRI, which it doesn't take a radiologist to see this stroke. Obviously, he has a cortical infarct in the right parietal cortex, which was affecting his arm and his leg. He had further workup and studies. MRI and MRA showed that stroke that I mentioned. His Dopplers were negative. He had an echo that was done, which showed a PFO. He had a hypercoagulable workup, which was negative. His patent foramen ovale was present. It was felt to be a high risk for embolism because he actually had an atrial septal aneurysm. And we do see a higher risk of paradoxical embolization when PFOs are associated with atrial septal aneurysms. His ejection fraction was normal. The remainder of his TTE was unremarkable. So this is sort of an example of what transcranial Dopplers look like in individuals. This is an example of a bubble study. So you see all these microembolic spikes that happen during a bubble injection. And then what you'll see as they die out, you'll see a few more residual little microembolic spikes. And then we go back to the usual. And so that's very helpful at picking up PFOs, as I mentioned. It was helpful in this case. So his PFO was confirmed by TE. He had no other structural heart disease. He had a negative hypercoagulable evaluation. He had no evidence of lower extremity DVTs. As I mentioned, anytime we see a PFO and we think it's paradoxical embolus, we look for clots elsewhere. And his PFO was successfully closed uneventfully 2 weeks later. When we talk about medical therapy for PFOs, so in an individual like this where you say, well, I don't want to close your PFO, but what can we do for you medically? We feel that all patients who have, at least who have a stroke, should use antithrombotic therapy, regardless of whether they're closed or not. The meta-analysis of the data appears to show there isn't a clear benefit to anticoagulation versus antiplatelet therapy, and a number of the trials have looked at this. The efficacy of PFO closure in patients requiring anticoagulation is uncertain. So in anyone who needs to be anticoagulated, we're not sure if closure in addition to anticoagulation is of benefit. But suffice it to say, antiplatelet therapy at this point seems reasonable. That's usually what we use at our center, and in some rare cases we'll use anticoagulation for different circumstances, but effectively we felt that antithrombotic therapy is reasonable. Here's the algorithm that I would say, sort of in closing, is a nice synopsis or way to look at cryptogenic stroke and decide what the next steps are in terms of management and workup and how to treat them. So firstly, we look at stroke patients. Are they under the age of 60? If the answer is yes, we say, does the imaging show a stroke that's not considered to be small vessel? Meaning, is it cortically based? Does it look like the type of stroke we'd see in an embolic event? Does the patient have an alternative risk factor that would explain the stroke? And that's why we really want to do a thorough investigation of looking at hypercoagulable risk factors, echocardiogram, looking for occult AFib, doing all the rest of the workup to say, are we really sure there's no underlying risk factor that we're missing here? And that's all these sort of tests that we talked about, right? So MRA, CTA of the head and neck, looking for dissection, TCD to look for PFO, transthoracic or transesophageal echo, hypercoagulable evals. And if all these things look okay, and the only thing you're finding is a PFO with shunting or size that is felt to confer an added risk, then we think it's reasonable to go ahead and proceed with PFO closure. We always like to do continuous cardiac monitoring, as I mentioned, for at least 1 month. There's obviously a lot of data, as I'm sure the cardiologists know, about putting in implantable loop recorders for longer periods of time, and I'm obviously very supportive of that. What was nice about the REDUCE trial in particular is we were looking at PFO closure as far as 6 months out from the stroke. So what we try to reassure patients of is, I don't believe there's a sense of urgency with PFO closure after a stroke. I think you can wait and do the appropriate workup, even if that involves several months of analysis and evaluation. You should really make sure you've done your due diligence before you commit to closure. Then when we talk about closure with patients, I think it's really important that they understand at least some of the basics and the specifics, which I would include as the following, saying that the absolute recurrent stroke risk reduction is about 3.4% at 5 years. We say the peri-procedural complication rate is about 3.9%. The non-peri-procedural atrial fibrillation rate is about 0.33% per year. And if you sort of review the practice advisory update, and this is from the American Academy of Neurology that was published last year in 2020, this is sort of what, or more or less what they recommend. I think it's helpful to keep all this in mind. So in patients with PFO felt to be causative for stroke, clinicians should provide counsel to the patients that PFO is common, meaning it's present in 1 in 4 adults. Causation of PFO and stroke etiology often lacks certainty. PFO closure probably reduces the stroke risk in select patients. And again, it's these same rates that we discussed. The number needed to treat is 29 patients to reduce 1 stroke at 5 years. The procedural complication risk is 3.9%. The non-peri-procedural risk of AFib is 0.33% per year. And most of those AFib events, you can reassure patients undergoing closure, are self-limited and are of uncertain long-term clinical consequences. These are, again, more of the 2020 updated recommendations from the American Academy of Neurology, that in patients being considered for PFO closure, clinicians should ensure that an appropriately thorough evaluation has been performed to rule out alternative mechanisms of stroke, and that if you have patients with a higher risk of, as an alternative mechanism of stroke, you should not routinely recommend PFO. So we really want to look at those other risk factors to make sure there isn't some alternative causative factor. The AAN Practice Recommendations suggest complete vascular imaging and EKG, and what I think is important is prolonged cardiac monitoring, particularly in the individuals mentioned here below, patients over the age of 50, patients with hypertension, patients with obesity, sleep apnea, anything that you think would result in structural heart disease that could potentially put them at risk for occult AFib. Those are ones where we would want to consider maybe longer duration of monitoring, perhaps with a loop recorder for several months. So in conclusion, for cryptogenic stroke and PFO, anticoagulation and antiplatelet therapy are equally effective if you're not going to do closure. So these are the medical recommendations.